chance to be involved in this fabulous organization and with this terrific meeting. I do have a talk, but let me first say that having thought about this meeting this last few months and listened to the various people who work with CINS about believing in building a healthy civil society, talking about building communities and connections and networks and relationships, what struck me was something that my colleague, Dr. Lori Brotto, says all the time, which is that when women are healthy, families are healthy. When families are healthy, communities are healthy, and that makes our whole society better. And so I really have clung to that in terms of understanding the very important role that women play in how our society rolls out overall. And I think what's really important to comment on is that in research and medical research now, we are seeing a vast underrepresentation of funding and endeavors directed towards women specifically. As you may all know, in the past, much research that was done, even cardiovascular disease, was only done in men. And so there had needed to be a real shift, because sometimes the data we found in men did not apply to women. And so this meeting is such a great opportunity to talk about building healthy societies and talk about how to cultivate research with great networks. And that's what this is. So I'm really pleased to be here. Oncologist, which means that I have been engaged over many years now in the treatment of women with ovarian cancer. Gynecologic oncology is the medical subspecialty of OBS-GYN, which means that we were trained to do surgery, chemotherapy for women who have gynecologic cancers, so predominantly ovarian, breast, cervical, ovarian, cervical, endometrial cancers. And I started in practice in that job in 2001. And over the years, it became really clear to me that there's got to be a better way, that I don't want to be engaged in the treatment of a woman with a terrible disease anymore. I want to be engaged in prevention. And that's really the philosophy that's launched a lot of the great conversations with Dr. Garg as we've tried to work on some shared research projects. So in particular, my main interest is quite narrow, but I think it will speak to this community, is about hereditary cancer prevention. And I'll tell you why that matters. I don't advance, sorry. That's very strange. I'm going to stop sharing and fix this real fast. Not sure what the issue is. Okay, there. So in Canada right now, there are about 4,000 women who are diagnosed with ovarian cancer specifically. And the thing about ovarian cancer, it is the most lethal gynecologic malignancy, and more than 70% of women who are diagnosed with it, in fact, have very advanced disease at diagnosis, because we don't have a screening test for ovarian cancer. So despite the fact that sometimes people get mixed up about a Pap test being checking for ovarian cancer, it isn't. Pap test is for cervical cancer. And we have huge studies all over the world, big trials of hundreds of thousands of women in the UK and the US that have shown if you did ultrasounds and blood work, you're still not really able to detect this disease at an early curable stage. So you can see then why that shift and that view for us has got to change to prevention. The challenge has been that figuring out the best prevention until this last few years has been very challenging. But there's one thing in this story of ovarian cancer that's really compelling, which is that 20% of women who end up developing an ovarian cancer turn out in the end to have an inherited predisposition. And of course, that begs the question, if we could have just found them before and offered them some preventative surgery, could we have saved all these lives? And as research has evolved, we're seeing that. So what does that really mean in practical terms? So some of you might have seen the news a decade ago now about movie star Angelina Jolie, who announced that she had something called a BRCA mutation. And this little diagram in the middle you'll see here is what we call a pedigree. And I draw these out of my clinic every day, and we're tracing out families. And so we've colored in people who've had a cancer in a black, circles are women, squares are men, and sadly, if somebody's deceased, there's a line. So it looks quite stark to look at, but it really does help us figure out families that are at risk. And so what we have learned now, because of that 20% business, that 20% of women who have ovarian cancer have an inherited predisposition like Angelina did, what we now know is that if we could just find them first, look at their family history, get the women who've already gotten an ovarian cancer in their family tested for these genes, that we can save lives. And in fact, it's really compelling, because what we've seen now is that of women that we can find before they get a cancer, if they have the appropriate screening and prevention, they have a 70% improvement in their all-cause mortality. And honestly, in medicine, for the medical people there, you'll know that there's not very much in medicine that gives you a 70% improvement. And so this field is evolving really quickly. And I'm showing you this great big huge pedigree of a family I've been caring for nearly 20 years. And I know it's hard to see, but you'll get the idea that there's lots of black along this generation of people who've had cancer diagnosis. But look down here lower, all of these relatives in this big family, none of the people in that family have gotten subsequent cancer. So in a meaningful way, once you implement access to research and testing and prevention, you can make a big difference for families. And we believe now, it's hard to get these data, but we believe now that perhaps these things exist in the general population at about 1%. And testing back in the day was tens of thousands of dollars, and now it's down to a couple $100. So there's really an opportunity here, I think, that's very exciting. So why bring this to CINS? So I recently was at a big research meeting, worldwide research meeting about BRCA. And one of the big problems that these huge research collaboratives have is that Northern European white people are vastly overrepresented in the research data sets, and that we don't really have good data for anybody who's not a Northern European. There are very few in this SIMBA data set, very few South Asian contributors, very few African contributors, and there's a real disparity in how we are including people in research. And what that means then is that if you're not included and given the opportunity to join research in the first place, how are you then going to get to benefit from the results? And we see this too in the way testing results go, where this orange on this graph here, the orange are people that get not a clear answer, but a we don't know answer. And the we don't know answer, meaning that they found a genetic change and we don't know yet what it means, is specifically a result of there being underrepresentation in research. So we got a lot of room to grow here. So how does this mean though in practical terms? So if you look at what needs to happen for an individual woman here in British Columbia to get along this pathway. So first off at the bottom, she's got to have some basic knowledge about genetics. She's got to know that these things exist. She's got to know, for example, that they can be passed on both sides of her mom or her dad's family, that in everybody's case, they get 2 copies of a gene, one from their mom and one from their dad. And one of them may have a spelling mistake in it, which is a cancer control gene, so that not everybody gets cancer, but you can suddenly see if you only have 1 copy of an important gene, why the risks tip. And so these are autosomal dominant. Not everybody gets a cancer, but the rates change. This lady then has got to get an access to a referral for genetic counseling, then to testing. And then once she's been found, then this whole prevention opportunity opens up. And there's an opportunity for her daughters, her mothers, her sisters to access prevention. So you get the idea now that this is pretty complicated. And this is a tricky process for even the most wealthy, white, educated woman. And for any woman who's got other barriers, be they language, education, recent immigration, whatever it is, this is going to be even harder again. So we came up with, as part of a project I did, or a program I did called Minerva, which is a women's leadership program, we were supposed to come up with our proposal. And this was my idea. And so we said, okay, we need to better understand the problem, identify the partnerships, identify the action points, design projects, and get a proposal to funding. And it goes without saying that the key partner and successful partner here was Dr. Garg and CINS. The other thing, though, Dr. Garg taught me was not to be reductive. And so it's real easy because you see a problem to then throw a solution at it. But you need to back up and say, okay, do I really understand this problem? And so he's really taught me to step back and take a big view with an integrative lens. So we did try to step back and understand the problem. And so here's some data unpublished so far from the Hereditary Cancer Program. Matthew Richardson was a master's student. And we knew that 8.2% of the BC population identifies being South Asian. But when we looked at Hereditary Cancer Program referrals, only 3.9% of people who got there were identified as South Asian. So there seems to be some difference in who's getting referred in the first place. So we know that there's an issue there. The bigger next issue that's come along is when we look at those people who did have testing, what happened and what did we find? And what we found in the Northern European people was that the risk of finding something substantial like a BRCA mutation was 11%. But for the people who were South Asian, we were finding a pathogenic variant in 23% of them. So there's a real signal there, and we don't know if it's because only the worst families were coming in, or if maybe there is a higher rate in South Asian families. We just don't know. And what's more, what I won't show you here in the interest of time is that also too, that orange uncertain report, which drives us all crazy and families really stressful because they don't know, we don't know what to tell them in their genetic testing report. That rate was 38% in the South Asian families and far vastly lower in European ancestry people. So we got to handle that there's a problem. So we had to figure out what are our next steps. So I've told you this, what we know is that South Asians are underrepresented. And when we look at the research and look at who's published elsewhere in the world, what we're seeing is that other places are reporting this. So in the UK, there's several publications talking about, barriers to care in South Asian women. So is it language? Is it systemic racism? It most certainly is. Is it related to education? And how much are there things like core values and core beliefs about cancer? And some families have told us that, they're worried about their family's reputation, that if, they found out there was something hereditary in the family, that could not be of interest to them to learn about it. So what do we do now? So we did a few things. First off, we spoke to a lot of physicians, and this particular lovely physician said, I agree the barriers in providing thorough and accurate information on complicated things is hard, even with a translator. She said, I understand Punjabi very well, but I'm slow with my communication. I'm sometimes surprised the translator isn't saying exactly what I meant. And we heard this as well from Dr. Alok Kumar, who's a medical oncologist in Surrey, who said he's hearing what the translator said, and he's thinking, that's not what I said. And it can become even more difficult. You can imagine if now suddenly you might have a family member translating a genetic issue where there's other dynamics there. So we were able to find a consent for genetic testing in Punjabi, and that's been a good start. And we've been able to identify some other resources to help with actual translation. The other issue, I think, is a lot of geography and service related things. For this population, I don't need to tell you where everyone lives. The biggest sort of the population is in Surrey, Abbotsford, and Delta, but we don't have any genetic counseling presence in Surrey. So that would be something that would be wonderful to discuss further. And then if we look at that evidence, like I've told you again, we're seeing again that other researchers are saying there's a problem with access to care, and there's some reluctance on the part of some families to even say the word cancer. And in my experience, many South Asian women with breast cancer won't say breast, they'll say chest. So we need to really better understand and not presume that we understand what their barriers are, where their fears are. So here's the team. My main group that I'm affiliated with is the Gynecologic Cancer Initiative, and the partnerships that we've struck now are between CINS and the Gynecologic Cancer Initiative. And we have Stephanie Lamb, Dr. Alok Kumar, who I already mentioned. Nia Seth is our research assistant, who's online here, and you would have met at the reception last night, and Dr. Lori Brado, of course. So we have now written 2 research grants and been successful. One is from, I'll show you this first. So this is the first draft of a recruitment poster for our first study. And so for this study, Nay has designed this with a friend of hers, and there's going to be a barcode. We're going to ethics now, and we're going to do a series of focus groups and interviews with South Asian women around the question of hereditary cancer and access to testing, just to try to better understand their needs. And then we've also been really fortunate to get funding not only from the Social Sciences and Humanities, SSHRC, but also from UBC with a community university engagement program that was funded through the Royal Columbian. So we're really excited about getting these projects going. We've got some further work done on translation of videos about cancer genetics. We've got some more media engagement projects planned. And so it's feeling really interesting, and stay tuned. And thank you.
Thank you, Lesa. Having had some awareness of the work that you were doing, because I had actually read over the research grants themselves, this is fascinating to actually hear you present it in this level of clarity, and what valuable and important work. A question that we have, and others, if you have questions, just put them into the chat box. One of the questions that we have here: if 20% of the BRCA1 positive women can get ovarian cancer, what is the risk percent of BRCA1 negative women potentially have for getting the cancer?
Right. This is I'm really glad brought up. This was really important that this was brought up. So in the general population of all comers, 1.3% of women in Canada will get an ovarian cancer. Amongst those, we will, if we go after the cancer's happened, we'll find a mutation in about 20% of women. But if you flip it the other way, so if you find a healthy, unaffected woman, because let's say her mom had ovaries, she had testing, the daughter had testing, the daughter would be at a 50% risk of finding that same mutation that her mom has. If she carries the mutation, if it's BRCA1, her lifetime risk for ovarian cancer is 44%. If it's BRCA2, her lifetime risk of ovarian cancer is about 17%. And the relative breast cancer risks are also elevated in the department of 60 to 80%. Men who can inherit this as well as women, often families forget that, men have an elevated rate of prostate cancer and can benefit from screening. And there is now new exciting research about screening for pancreatic cancer. There's also a slightly higher rate of skin melanomas. So this is not just a women's issue. I've obviously focused on women, but these genes don't care what gender the person they're in. They are passed one way or another. And we've seen this in some of our patients where I've had Irish patients who presumed you could only get a breast ovarian cancer gene on your mom's side. And I've had South Asian patients who presumed you could only get it on your dad's side. And that is not the case.
Oh, thank you. Another question: should we offer, actually it's from the same thing as Dr. Kumar, the same person, Dr. Kumar. Should we offer BRCA1 testing to everyone?
Oh, so that question of population-based testing is my other main passion. It goes without saying, though, that would be a complex process for health systems to implement. It absolutely is where we're going to head as testing becomes cheaper. I think there's lots of things in healthcare we spend $300, $500 on for people that probably would have less yield than this could down the line. But we got to get our systems improved a bit more yet before that would be ready. I do say, though, that if we were to embark on a population-based testing studies, that we would first off start with those people who are least able to access the services in the beginning. So in my opinion, Indigenous people, new immigrants, people of color, not Northern Europeans. I think we would need to start with the people who've not gotten the service properly in the beginning.
Mm-hmm. Very good. And I have my own personal question. Then I forgot because I got so interested in your answers. Do we have any other questions in the chat box? I'm just going back here now and see. No. So very good, Lesa. If we have no other, wait, no, we do. We have lots of thanks coming through, Lesa. I am the co-chair of the Division of Family Practice, Surrey North Delta. Feel free to connect. So that's a message that we can get to you after. So this is what we love to see here at CINS is because we are about connections and networking. So love to see people reaching out and saying, let's connect, because that's what we want. We're an action-oriented organization. So thank you very much, Lesa.